In 2017 in Florida, Laura Gilkey wrote daily blog entries about her 9-year-old son Benjamin's battle with cancer.
Benjamin is our youngest son, and he completed our family. He was only a week into his 7th year when he was diagnosed, so he was still a very little boy, and he was hilarious, and we called him Spicy. He was very spicy. The biggest kid in the room by stature and also personality.
In 2016 in Colorado, 83-year-old James Allen Graham struggled to regain his energy after a heart valve replacement.
He grew up in small-town Colorado. He started out his career as a brick mason doing construction, had lots of friends in the San Luis Valley. But his real passion came about in his 50s when he changed careers to be a photographer.
Both Benjamin and James had hematological malignancies, cancers that affected their blood and lymphatic systems.
So he was diagnosed with acute lymphoblastic leukemia, which is the most common and the most curable childhood cancer. So at the beginning we found relief easily with the numbers because it's like 85–90% cure rate. But we didn't know then that he also had an underlying genetic predisposition. It's called constitutional mismatch repair deficiency syndrome. So basically, his DNA was unable to repair itself. So all of the little, oxidations or replications that we all fight off to not get cancer every day, his body ultimately was unable to do that. And so there's only been like 147 cases of this reported ever. We found that out about a month before he relapsed. And so if he had survived the leukemia, which we fully expected him to, we never thought that that's what would, take his life, but he would have continued to get multiple cancers throughout his childhood. The kids that have CMMRD don't live to adulthood, so.
During one of his regular checkups after his heart surgery, they went to the doctor's office, they took one look at him, sat him down, and immediately drew blood to check his hemoglobin and hematocrit, and it was extremely low. So they sent him to an oncologist, and they did a bone marrow aspiration at that time, and he was diagnosed with myelodysplastic syndrome, or MDS. It's really a blood cancer, and it eventually progresses to where the bone marrow just doesn't make red cells or platelets, and in some cases, white cells. And so you're at risk for infection.
Anybody with any type of hematologic disorder or hematopoietic disorder will often need blood products because their bone marrow isn't functioning. They can't make those red cells, and therefore they will need those blood products to be given. So anybody with leukemia or lymphoma will often need blood products. Platelets, or the little clotting substances that are needed when you cut or bleed, also often anybody who has some kind of problem with their bone marrow will need those. So anybody who has any type of hematologic disorder like leukemia or lymphoma will often need platelets as well.
Benji started needing transfusions right away because the leukemia cells attacked everything. And like I said, that's how we knew that he was even sick, is because he started getting significant abnormal bruising all over his body, and it's because his platelet count was, the first time we took him to get his blood tested, I think it was 13,000. A normal range starts, I think, at 150 or 250,000. By the time we got to Johns Hopkins All Children's, it was down to 6,000, which at that point is, you can get a brain bleed.
When he would go and get the transfusions in the beginning, he would feel much better. He for at least for a week or so, he would feel like he was normal again. He could walk across the yard. He could go into the garage and work on cars, and he liked to do woodworking as well. And he could do a little woodworking. He never got up to mowing the lawn or anything like that, but he could walk. He could take the dog for a walk. He could be active.
His transfusions didn't last very long at the end of his life at all. I mean, sometimes the numbers reflected that they really hardly made a dent in things, especially platelets. But I can definitely say they made him more comfortable. It's not an exaggeration to say that he never complained about it. I mean, there were things that were painful, and he would grimace or sometimes even cry, but he just moved past the treatment as quickly as he could, and went right back into experiencing joy. Like, he never let anything he had to go through get the best of him. And when it was over, he didn't go there again. You know what I mean? He didn't. And so in order to get back to that joyful place, he was extremely brave.
He never complained of pain. He complained of being tired. He complained of this isn't the way I want to live. It's not being able to do anything.
Things changed so quickly, every day there, especially, before there were no other options. There was always another option. It was always quickly trying to find something else. And then when they told us that there were no other options, it was quickly trying to make him as comfortable as possible. He was just so involved in his care, and he knew that he had to have his port redressed every 7 days. And I told him it was coming up on the next day. But once we found out he was dying, we weren't going to put him through that. He hated that part of it. He still never complained, but he did not like that part. So I told him, you don't have to get your port redressed tomorrow because you're not getting any treatment anymore. And he said, then what are we doing here? Why can't we go home? And at that point I was like, oh, so we started having the conversations. Again, his moments of lucidity were few and far between, and that conversation was a short one. I think in the bathtub, which is where he was most comfortable. He may have slept for the next 8 hours, but during that time, we started trying to get the ball rolling of, anything he said we wanted to make happen.
Going home for Benjamin, James, and other terminally ill patients means going on hospice care for pain management and other palliative care.
People have really powerful and solid ideas if they're told you have this amount of time to live. Now that's not, that's nobody's crystal ball, but you can imagine if you were given 3 months to live, you'd probably be pretty decisive about how you want to spend those 3 months. And most people don't want them to be in an ICU or in a hospital or going to the lab, getting blood drawn and things like that.
I used to joke with my parents that being ill is a full-time job, because they would spend a lot of their time driving back and forth to the hospital, and then when you're in the hospital getting a transfusion, that takes anywhere from 2 to 4 hours, depending on how much blood you're getting. So, and it's boring. I mean, you're just sitting there getting a blood transfusion, and my mom was reading a book or, doing her embroidery, and so it's not very active. And the thing that they really loved was interacting with people. And so all of a sudden, when you have an illness, it takes you out of that exchange of friends. And church members knew what was going on, so they had a support system. But still, you're focused 100% on getting better.
Hospice is an environment where the social part is much more important than the physiologic. The disease progression is going to be what it is. The family, the caregivers have made a decision to let that disease follow its natural course, but it doesn't mean you have to feel bad if there's relief available. That certainly works with pain management. Palliative pain relief is certainly number one in a hospice environment. You want the person to feel as comfortable as they can with regard to pain. Well, why not as comfortable as possible with regard to fatigue and their energy level and their ability to make the most out of those last days that the family has made a decision to grab onto. Usually in a hospice, it's like, let's have the best quality of care. Let's not spend our time driving around hospital parking lots or trying to figure out, how to connect in the maze of the hospital to find the people you have to find. You're looking probably at that moment for, let's make this as comfortable and as positive an experience for everybody involved. And blood is part of that.
When a patient is an oncology patient, though, and might have disease in their bone marrow, particularly leukemia, or if they have some other cancer that's metastasized to the bone marrow, or it might be ideal to have transfusions to help help prolong their life, then it is difficult sometimes with hospice because not all of them allow transfusions. And where we live here, our hospices are divided up by county, and some of our hospices, at least 2 of them, will do transfusions at home. So when we have an inpatient who is at the end of life and they're willing to go home, they'd like to go home, they are happy to have hospice come in, and it's in one of those areas where we know we can get transfusions to the home, then it makes that decision very easy. But if it's a family that lives in one of those other counties where we can't get transfusions, then a lot of times they will make that difficult decision to trade off going home to staying and having the last days in the hospital.
We never had a concrete conversation like, this is what palliative care means, this is what hospice care means, this is the difference if you take him home versus if you keep him in the hospital. But I think that's because things were changing so quickly, and everybody was just, his comfort was everybody's primary goal.
When we talked to the hospital, because I wanted him to get a platelet and a red cell transfusion, they said, well, he has to stay in the hospital to do that. He can't get that at home. And we really wanted him to get home because we knew timing was imminent. And so then it became a question of, well, do we transfuse him in hospital so he can at least have the energy to get home, and risk that he doesn't get his wish, which is to die at home? Or do we just rush him home and hope for the best?
Every year there are 70,000 individuals that have hematologic malignancies. And very few of those, less than 5%, probably less than 3% of those individuals ever make it to being able to get any support in palliative care. Now, a lot of those get cured, thank goodness, but many of them don't, and for those, they deserve as much as anyone else the opportunity to live their lives all the way to the end the way they want to live their lives, and to not be able to have the same rights that anyone else has to script out the way they feel that they should be able to live the end portions of their lives is completely unfair.
And we wanted what he wanted. Now we were all dead set on that. It's like he wanted to be home. He wanted to be in the chair that he sits in all the time. He wanted to have the people that he loves around him. He wanted familiarity. That's what he wanted. You wouldn't believe that when we did bring him home, the people that just were there, and kids from the high school who were there, but he didn't last long enough once he got home to really even be cognizant of the fact that they were there. So that's the regret.
James Graham died at home on April 9th, 2016. The Grahams were never given the option of getting transfusions for him at home. When Laura wrote in her blog that Benji wanted to go home, things were different for the Gilkeys.
When we first started the conversation about bringing him home, we were told that he could not have platelet transfusions at home.
There was no way to get him out of the hospital without providing that at home. I knew that after talking to them. It was either you have to stop them or go home, and then we have to go in, which is, how is that quality of life, running back and forth, to a lab every day to have hours of transfusions.
People moved heaven and earth to try to get him home. I mean, so many people, after they read my entry that night about him wanting to be home, they contacted, CEOs of the blood bank here and all these higher up people. I mean, I wonder how many phone calls he got, because, I think I must have written in there that part of the decision, part of the barrier to getting him home was this platelet issue, because he needed platelets all the time.
We did get the blood bank on the horn, and they were very interested, which I loved. That was a huge thing for me as a nurse. I'm like, we were really tapping ground, at least that I had not entered in my 20 years of hospice nursing, doing blood products at home, but I didn't see why it couldn't be done.
What really struck home with me was Benjamin and his mom, wanting to really see this through. And when I knew that the child is away from home in a hospital, which could be a cold, sterile room, which is totally different than being with your family and loved ones at your last days. And I knew that if we can get this child some blood products, they're going to feel better. He's going to have a few better days left that he can relate with the family. The mom can have a better relationship at the end of this. And so I became driven to do this and say, we got to do it. Even if we have to just give and donate the products to them, we're going to do that just to make this happen.
Tidewell Hospice sent representatives to meet with us so we could get our questions answered. Palliative care was in that meeting, as well as some nurses and maybe a physician. We had all our questions answered, and I felt like I was ready to make the decision to try to get him home. And then I remember walking out of the room with the nurse practitioner, our friend, and I asked her if we could meet privately out of Benji's room, because I wanted to know what would happen when he died. Not what would happen, but what the care would look like and what we were responsible for, what they were responsible for. So she said yes. She took us into a private room. I think Mike stayed with Benji, maybe a nurse. And this meeting in this private room took 5 minutes, 10 minutes, and within that time, everything changed. I remember Dr. Morelli, who's on the palliative care team, took a phone call and came back in that room, and his face just had looked different. He looked disappointed. And he had gotten a call from the physician at Hospice who said, I just don't think we can meet his needs at home. It was and that physician later found me at a blood drive and introduced himself to me. And I was very grateful that he did that, because he probably thought I was thinking he was the bad guy or something, but they couldn't meet his needs at home. I mean, 48 hours, at that point, I don't remember the last time he had gone 2 days without a transfusion. And maybe seconds later, my husband walked in the room and said, Benji's crying for you. He took my place to get the information I had just gotten. I went in the room and I saw him in worse pain than I've ever seen him in my life. And I just knew at that moment that we needed to keep him there. And I remember the Tidewell people were still there, and I said, I need to ask my son what he wants, And he just wanted to be in the bathtub. And I asked him, I said, do you think you can stay here? Do you think you can be comfortable here? And I could have been asking, he did not care at that point. He just wanted to be, out of pain. And I feel really grateful that people tried so hard to get him home. Of course, I wish that he could have been home if that's what he wanted, but it would have been more painful to get him here. He wouldn't have had what he needed here. And those nurses took such good care of us, and I don't know that I could have done it without him.
Benjamin Gilkey died on February 11th, 2017 in the hospital. The cooperation of his doctors, palliative care team, hospice officials, and the blood bank nearly allowed Benjamin the opportunity to pass away in the comfort of his home.
It took a pediatric patient to make that happen. Children, of course, are so different. It's not the same as adults. But I would like to see that happen across the board.
I would really like to see patients be able to routinely get transfusions at home, because the hospice provides so many other good supports. They bring in whatever they need as far as hospital beds, bedside commodes, equipment, medications, IV medications, oral medications, oxygen, suction equipment. They provide many other medications, the maintenance home medications a lot of the patients are on. They provide a lot of times family support. They have some sibling support groups. They have grief recovery groups. So it really seems to be one of the biggest pieces that's missing, is to be able to do the transfusions at home.
Hardly anyone that I know of is really bringing this forward. Anyone is really concentrating on this effort for a palliative care or transfusion, not just in a palliative care setting, but in a hospice kind of setting. I think it's almost written off that, hey, we can't do it, or it's done at a hospital. That's your two options. You can't do it, or it's at a hospital.
It's a misconception. I think there are, because it's all individual-based, organizationally. Some are for-profit hospices. We are not for-profit. I don't know that always makes a difference, but some don't offer the same treatment or allow them because of the financial burden of it. And that's healthcare in general. So for example, with the blood transfusions, if you're getting routine reimbursement under Medicare is around, I don't know, about $150 to $160 a day for a hospice patient at home. So one blood transfusion, 1 unit of packed red blood cells, or that between the human resource, the equipment, the blood product itself would far outweigh even a month's reimbursement.
I think nobody's been able to crystallize the challenge and connect the people with the solution. And when I say crystallize the challenge, a lot of people who come into hospice, it's probably their first time in hospice. Certainly if they need transfusion, that's probably not been an element even if they've had other relatives in hospice. And once they do that, they have to know enough about transfusion to know what it is they're trying to fix, i.e. the fatigue and the, so that requires a fair bit of medical understanding. And then they're usually on a short time frame. So their loved one might be dealing with this for 2 weeks, maybe a month. For them to start working through the system to answer the question of transfusion in that short a time frame is going to be overwhelming. It's just too hard to tie all those pieces together.
The other part of that, I think, is just awareness. They just don't know. There's no education for that. There's no education for the donors. That really a blood product is really a drug. It's a biologic that is made to transfuse into someone else to make them healthy. So it is a drug. They can ask for that. I don't think the public knows enough to say, hey, I want this product because I know it's going to make my family member feel better.
One of the things we don't do a particularly good job of in this country is bringing the patient into the transfusion decision. Most people don't know much about blood till they start getting it. Most people don't get it chronically, so they don't develop kind of an experience and a sophistication around what's going on.
There wasn't a whole lot of time, or at that point, a lack of emotion, so you could weigh your options to kind of figure out what you wanted to do. So if I had it to do over again, or if I would advise someone who was going through this, find out what your hospice options are early on so that you can make the right decision in an impassionate way.
As a subspecialty, oncologists get a bad rap for not doing a good job of talking about limits of care. As a group, we all do. Part of that is because many patients feel that if I start talking to you about limits of care, that means I've given up. However, in hematologic malignancies specifically, we know that we don't have a good option. And I think that speaks to it. If we know that the only option I have for palliative care is to tell you that I can't give it to you because you won't be able to get any red cells or you won't be able to get any platelets if I put you on hospice, and that's a really bad option, that's why we don't refer.
For a patient who is just trying to have their last few days, weeks, or a month or so maybe of good quality life, the transfusions can make all the difference, because if it's a blood product, then that gives them basically the energy to get up and have breakfast, maybe go out on a outing with their family to the beach or whatever their favorite things are to do. The platelets are important because without platelets, then there's spontaneous bleeding, and it's very uncomfortable for anyone to see bleeding out of the nose, the mouth, and in those areas. And so even though it doesn't really contribute to the quality of life the same way the red cells do, it's not comfortable for anyone to see bleeding.
For patients who rely on transfusions for energy and pain relief, blood is one of the palliative drugs that they need in hospice care.
It's a medication. You just have to make sure you're prepared to infuse it correctly through an IV. And then, so you have to have that protocol, which most medical facilities can give IVs. And then you need to have the staff capable of handling a reaction.
I mean, we do all kinds of IVs, administration and transparenteral nutrition and, central lines. All that can be safely administered in the home. And I think a lot of people, it's still just the stigma of You sign up with hospice, they get the liquid morphine, they get you a hospital bed, when in fact that should be the last moments, and it's just too late a referral. That's never the case if you refer early.
I do think it is also certainly the physicians that can do it. They are the one prescribing. It's basically a prescription for a blood cell or for a platelet. And like I said, it's a drug, so it is a prescription. If they're not going to prescribe it or recommend it, then it's not going to happen, and no one else knows to make that happen.
Nobody should stop blood transfusions when it still has a benefit. If it does give you more energy, you know, if it makes you less short of breath, you know, if it can do those sort of things, a transfusion, absolutely, it's palliative. There's no question. You know, but I think it takes a room of clinicians to come to that conclusion and say, or try it and see if there's a difference with or without it. You know, a lot of people think if you stop blood transfusions, you're going to automatically die, and that's not the case. And I don't think anybody wants to stop a transfusion if it has benefit. You know, I don't see that in my own practice. I think some hospices are much more cut and dry. I think it's easier to bring people onto service when you can gradually talk to them and bring them around to understanding. But I think off the bat, not necessarily everything's off the table, but some will be much more costly, and that is not considered right now during the hospice reimbursement. You know, whether we're giving you pills for pain, which are much cheaper than a unit of packed cells, doesn't mean they don't have the same palliative effect.
It's not impossible, but it's very impractical in a home setting. Because basically it's going to come down to the agreement. You have to have, you know, whether it's a vendor agreement, there is some liability, there's some legal that you have to go through and some contract negotiations. So if you're doing it in a home health or a home setting, it's impractical, but it's not impossible. That doesn't happen, I don't believe, very much. In a hospice setting, you still run into some issues. You still have to have the blood agreement done, and those, what we've learned, you have to have those done ahead of time. Because by the time you find out, hey, there's a need for blood, that someone wants it, when they're in hospice care, their days, unfortunately, are numbered. And by the time it takes you to work the contract, get your legal, their legal and everything done, sometimes it's too late. And that was one of the cases, one of the instances in this case.
This is about kids and grandkids, and this is about people trying to come to terms with their maker in a way that is more positive than hey, I feel lousy today. Wish I had some energy.
If people can move heaven and earth for Benji to be able to go home and get what he needed, then I'm sure it can happen. And maybe there just needs to be a precedent set, or those pieces in place, you know, I know home health care and the blood bank and hospice were like the triangle of people that were communicating to make it happen. The hurdles were moved very quickly, and it just wasn't quickly enough, because it would have, honestly, had to have been the same day. It would have had to have been in place, you know, for us to really be able to take him home.